So this article is about nurses are burned out and fed up for good reason. We just had a strike here in New York City. Lasted for like 3 days. They brought in traveling nurses. Not sure from where, but this was at Montefiore in the Bronx and Mount Sinai in Manhattan. I believe Mount Sinai Hospital up on Madison Avenue, Upper East Side. Anyway, so here it goes. This is more like an opinion piece, not really news, even though it says in the news here. But a lot of this, if you read the article, it's based on how the author feels. So nurses are burned out and fed up for good reason. It is enraging but not particularly surprising that our healthcare system is failing the most essential of its workers. Nurses are the keystone holding up our rickety and raggedly uneven healthcare system. We desperately need more of them, but we have created a healthcare system, indeed a broader society, that as if by design devalues them and takes them for granted. Yep, for granted. Let's see right there. Okay. Like workers in other female-dominated professions in the care industry, nurses are spoken of with a whiff of condescension as heroes. But just like teachers, social workers, health aides, daycare workers, and mothers, we sure don't treat them that way. Right? In the early days of the COVID-19 pandemic, America's nurses were rightly praised for the central role they played. But nurses are burned out. Many are simply leaving the profession. Thousands across the country are doing what the nurses at Montefiore and Mount Sinai in New York City did last week: go on strike. Their number one demand is not more pay or better benefits, the traditional stuff of labor negotiations. Instead, they want hospitals and nursing homes to hire more nurses and commit to set ratios of patients to nurses, something institutions have long resisted, in order to reduce their workload and increase patient safety. In a major victory for the nurses union, Mount Sinai and Montefiore Medical Centers, two of the biggest in New York, agreed last week to do just that, ending the strike in 3 days. Given how heavily regulated and bureaucratic America's healthcare system is, it may come as a surprise that hospitals aren't legally required to have a certain number of nurses on hand per patient, especially since similar rules are in place in other highly regulated industries. Federal regulations require a strict minimum number of flight attendants on each flight, depending on the type of aircraft. If the airline is even one short, the plane remains on the tarmac. Yet nurses in an intensive care unit, a cancer ward, an emergency room, or a labor and delivery ward can routinely find themselves juggling many more patients than common sense would suggest they could care for. Never mind best practices recommended by medical experts. One striking nurse I interviewed last week told me that he routinely had to juggle 15 to 20 patients, significantly more than the recommended number. Only California regulates the ratio of nurse staffing in every hospital unit. Efforts to expand this practice elsewhere have failed. This is not a problem created by the pandemic. For years, America has been grappling with a nursing crisis, which is now peaking just as our healthcare system faces perhaps the biggest challenge in its history: the relentless care needs of the aging baby boomer generation. Yet, at precisely this moment, when demand for health care is surging and pay for nurses is rising, tens of thousands of nurses have already fled the profession. Even before the pandemic, surveys showed that roughly half of nurses reported experiencing burnt out, and 1 in 4 were planning to leave their job in the next year. Now it is about 1 in 3. By 2025, the U.S. healthcare system could be short as many as 450,000 nurses. We have known for a long time that inadequate nurse staffing leads to more patient deaths. In a 2002 peer-reviewed study, researchers found that each additional patient assigned to a hospital nurse increased the likelihood of death by 7%. And yet, understanding is the rule, not the exception. How did we get here? America depends more on healthcare per capita than any other developed nation, right? So America spends more on healthcare per capita than any other developed nation. But what we get in return is a highly uneven set of health outcomes. We pride ourselves on leading scientific advancement of medicine and the quality of specialists who treat serious illness requiring advanced care is envied the world over. But the United States is near the bottom of the list of developed nations on some of the most common health problems like asthma, diabetes, and heart disease. It is a scandal that America's maternal mortality rate is more than double that of many other wealthy nations. There are many factors that lead to these poor outcomes, many of them systemic, like poverty and racism. But a major reason we are sicker and live shorter lives on average than people in other rich nations is our lack of access to the kind of basic primary care and monitoring that is the bedrock of nursing. It is not a sexy thing, but that's really what we do day in and day out. Control the traffic and be the beacon for problems and get the right people in the room when something's going wrong, said Christopher Fries, a professor of nursing at the University of Michigan. Hospital administrators say they are desperate to hire more nurses. Mount Sinai and Montefiore, for instance, have hundreds of openings they have not been able to fill. Part of the problem is that there just aren't enough nurses who want to work in hospitals, largely for the reasons I have outlined: overworked and a feeling of futility from not being able to provide adequate care. This leads to a vicious cycle as nurses flee jobs in hospitals or professions altogether early in their careers, making it all the more difficult to attract new ones. Hospitals operate under the brutal and confounding economics of American healthcare. Medicare and Medicaid reimbursement rates are set by the government, and, according to the hospitals, don't cover the actual cost of care. Private insurance companies negotiate to pay as little as they can, frequently creating perverse incentives that skew care toward expensive, high-tech testing and procedures and away from the labor-intensive basics of primary care. So when it is time to cut costs, administrators inevitably look at labor, and nurses almost always make up the biggest workforce, said Alexei Nazem, a physician and the chief executive of Nomad Health, a health care staffing company. Our system treats nurses more as a cost center than a value creator, so that the goal in too many cases becomes as few nurses as possible, caring for as many patients as possible. That is incredibly short-sighted, Linda Eichen, a professor of nursing at the University of Pennsylvania, told me. In 2021, she and a group of researchers published a study examining proposed legislation in New York that would require hospitals to meet minimum nursing staffing ratios. They studied a group of Medicare patients in New York and found that better staffing ratios could have prevented more than 4,000 deaths and saved upward of $700 million in medical costs over a 2-year period, a conservative estimate given the scope of the study. But the hospital industry lobbied hard against the proposed bill, arguing that hospitals need more staffing flexibility. According to the Healthcare Association of New York State, an industry group, 4 of the hospitals in the state are either losing money or operating on unsustainable margins. Hospitals are pretty much driven by their balance sheet and not over the long term, Eichen told me. The version of the New York legislation that ultimately passed did not include fixed staffing ratios, mandating instead that a committee of nurses and hospital administrators work together to set ratios. If they cannot agree, the law permits the hospital to unilaterally impose its own staffing plan. So you're back to square one. This is a real missed opportunity. Like many caring professions, nursing has long been undervalued and taken for granted. It is not a coincidence that these jobs, like so many others that involve caring for others, are performed overwhelmingly by women, though the number of male nurses has been growing. Gabriel Winnett, a labor historian at the University of Chicago, who has written a book about healthcare, said that the failure to value care work of all kinds hurts everyone's. Quotation here. The only way in our society people get access to care is 1. A woman does it for free through the family, or 2. An industry figures out how to make money off of it. Unquote. The pandemic showed us all how frayed and unsustainable our systems of care are. Nurses sit at the top of the care hierarchy, and they have a big role to play in transforming the ways we value care work. went on and said, we could imagine nurses at the leadership of a broad, small, democratic coalition or movement for higher quality care for all, he told me. We spend a lot of time in our politics talking about the need for meaningful jobs that support a middle-class life. It is hard to imagine a more meaningful job than nursing, but to get people interested in doing this job and sticking with it for the long haul, we need to invest in making it sustainable as a long-term career, imbued with the respect and dignity it deserves. Our lives depend on it. Well, I remember it was 2006 at a nursing home that I did per diem work for, and this has happened before where they, you come in. I was working the night shift, and I come in, they don't say anything, and then you find out that, wow, the nurse is supposed to come in, didn't come in. They didn't bring anybody else in. I mean, even though they had like several agency books, they could call somebody, bring somebody in. Oh, you can even have like a mandatory stay over. Somebody working an evening shift. That happened. I think it happened a couple of times, and then I put it in writing. They say the pen is mightier than the sword. Don't ever just say, look, you should do this or do that. No. You always put things in writing, and that's what saved me. I put it in writing. And I said, next time something like this happens, I'm just going to leave. And it did happen. And we're talking about, okay, normally my end will be like 30 residents in the nursing home on one side. And the other side is 30 for another nurse. So that comes out to 60. And then what happened is that, so I have like, this person didn't come in when I came to the nursing office, never told me I'll be alone. That's not fair to say, well, look, this is what it's going to be tonight, you'll be by yourself. No forewarning, no anything like that, which would be fair. At least you could say, okay, this person was being upfront, so let me give them an opportunity to work with them. No, nothing like that. So you go in there, and then you get a call later saying, well, you'll be working by yourself. That means you got 60 patients. And that particular floor was the toughest, and they had like a doctor who would come in late in the evening, and he would write a whole bunch of new orders that you have to pick up. So you have to transcribe these orders and put them in the medics, which is a lot. And he had a lot of stuff like labs that the patient had to do, blood work, stuff like that, other things like that, plus the regular medication. All that has to be picked up, which, by the way, will really slow you down. If you going through all those different orders. And he had a lot. And then you still have the other work to do. So I said, that's it. I'm leaving. And the supervisor at the time, she told me, well, I'm going to file a complaint with you against the state nursing board. And I told her, you go ahead. And I left. I've never been back there. But when the agency contacted me, I told them, yeah, I did give them a warning. And so I faxed it to them, but they couldn't write it. They couldn't read it. So I had to send a copy of it through the mail for them. Yeah. And that's what I did. And they said, well, don't send me by day to work. Well, you know what? New York City has a lot of places you can work. You don't need to work in a place that has a slave mentality. Just like this article said, I mean, come on. You have 60 different patients. It's not only that you can't. You're picking up all these different orders, and then you have to write in the charts too. And every every resident that's on the 24-hour report, you have to write. So the supervisor at the time said, well, what she is willing to do, she would write in the charts. Yeah, big deal. All you have to do is write maybe a couple sentences. That's it, you know. Like you put in the vital signs and so forth. Write something short. And she has all these other floors she got to go to and so forth. Her job is not the same, you know. It's very, very stressful. Take it from me. I understand what they're talking about. And I've worked in the hospital too, on the med-surg floor, and even a step-down unit. I used to work in there. So I know what the pressure, of course, the hospital, you have a much better ratio of patients than like in a nursing home. But the hospital, you have the acute care. So you don't see as many. Now, I was thinking, like years ago, I worked in a hotel, and I know that, like people, like the maids or what have you, who do the cleaning in the rooms and so forth, they have a certain amount of rooms that each person would have to do. I think it's like maybe 8 or 10 rooms. I think that's how it works. However, there are times the hotels would slow down, right? Whereby you don't have enough guests or what have you. And then the management will make arrangements, see, well, okay, we can only bring in so many staff. And, you know, because we're not going to bring in all the staff like we have a full hotel where all the rooms are full. We're not going to do that. So they would use this process to kind of step down a bit. And maybe instead of coming 5 days, some people come in like 3 days or so forth. And, you know, they still have a job, but they're not going to be paid the same. So I was thinking maybe nursing they can do something like that, because the hospitals are trying to argue that, well, we need flexibility. That's what they're arguing. They're saying we can't just say, well, we're going to put so many nurses per amount of patients in the hospital, which is like what the hotels do, you know. When the hotels have like so many empty rooms, you're not going to bring in so many maids to be cleaning when you have like maybe 30% of your rooms are empty. You don't have guests in those rooms, so same thing. If you don't have enough patients to fill those beds, well, then maybe you can do like the hospital, like the hospital association. That's what they came up with. So you bring in less staff to clean because you don't have any rooms to clean. You only have so many rooms to clean. So maybe they can do something like that, mirror that, like in the hotel industry. Maybe that can work for them. Because I know people are going to say, well, you know, I need my money, I need to pay my rent, I have a certain lifestyle. But it's still better to have a job, and one that's less stressful, than to have none at all. That's my take on it. But yeah, they do have some point about the staffing. Hospital staffing, like what the numbers they gave there about, you know, how many the male nurse, how many people he was taking care of. That's really ridiculous. Because you could really make mistakes that way. You could pull the wrong bag, the IV bag, and think you're hooking up this when you're hooking up something else, or you're seeing this medication and you have the wrong medication. Different names, like what happened to that woman in Tennessee, that nurse. She put in I think she put in like maybe a few letters into the computer system. When I used to work in the hospital, there was a system called the Pick-6 system, where you can put in the name of the drug and so forth for the person, for the patient. and they give you the drug. And she messed up badly. She put in like 3 letters, and a different drug came out, and she pulled the wrong drug. She pulled the kind of drug that would like more like hypnotize the body, or paralyze the body, instead of like a tranquilizer to keep calm, you know. And that ended up killing the patient, and they put her on trial for that. So I'm just saying, this is the kind of stuff that can happen. I don't know about the hospital where she worked, but more than likely, probably was really busy and so forth. Now, I have to say that when I was working in the hospital back then, we didn't have any smartphones, you know. So life was different. You had to go to a book, look, see if you find a book that has the name of the drug. Nowadays, I think everybody has a smartphone, and I think every nurse has a smartphone. So there's really no excuse to be making that kind of error, because with a smartphone, you could pull out the name of the drug that you think you have, right? And you can see right away, well, this is the name, you know. This is not the generic name, or this is not the brand name, so maybe I do have the wrong drug. And right away, you know, a smartphone can save you from going to court or being prosecuted for something. Like the place I currently work, they give this drug Paxlovid, like for treatment of COVID and so forth, for those who may request it. And one of the providers, she sent me a whole, like she texted me like she texted me a list. I think it comes from the CDC, and it shows like either the CDC or FDA, one of them. It shows like a whole bunch of different drugs that you have to be really careful. You can have an adverse reaction if you were to give Paxlovid, you know. So you have to, I mean, like sildenafil, things like that, which would be like Viagra, so forth. Other things for anxiety drugs for people who have problems, you know, like maybe for psychosis or stuff like that. All these different kind of drugs. And this particular person, the provider, she doesn't really want to like prescribe this drug, this Paxlovid, unless she really has to, you know, because she's afraid that down the line something can happen. You see, but some of the sites she works at, people will come in and they will say, "Oh, you know, this is what I want, this and so forth." And unfortunately, they put up something, I think, on the New York City website about you could just come in and show a positive, and you can ask for the drug, which to me is really wrong, because if you go into the prescriber should be able to make a judgment whether they should give you that drug. Not because you turn out to be positive, you could just come in and say, this is what I want Paxlovid, and they should give it to you. And there are people who make a big fuss. Just yesterday I saw that. There was a lady who said she's going to call 311, which is a number here in New York City. You could call to file complaints or get information, because she wasn't given the Paxlovid. So her thing is, look, she tested positive, she came in, she showed it, and that's the end of that. And the prescriber was saying, no, you know. No, I want you to test right here. I'm going to do the test. The test is free. I want you to test. And the lady refused. She wouldn't do the test at all. So you have to put it, you're going to put up with these kind of stresses, you know, if you're working in the healthcare system. And the lady went away and she said she's gonna call the hotline where you could file a complaint. Now, if you call the hotline, you probably could take, I don't know, maybe half hour to an hour, maybe waiting to get somebody to come listen. Where this test, the test is done really quickly, and you get the results in 15 minutes. So you have to ask yourself, who are these people that say, oh, I'm positive, I want the drug, I'm not going to redo the test with you. If you don't give it to me, I'm going to call and I'm going to complain. So this is the kind of stuff people put up with, and no wonder some people just say, I'm just going to leave the profession totally. I'm going to go into something completely different with less stress.